I hope ان اليوم يبقى مثمر لينا كلنا ونتعلم كلنا حاجة جديدة، وسعداء بان احنا بنشوفكم كل سنة. وهنبدأ علشان السكيدول عندنا النهاردة ان شاء الله طويل، ف let's start ان شاء الله. بسم الله.
بسم الله الرحمن الرحيم. بهنئ اخواتي وزملائي الاساتذه في قسم النيوناتولوجي بالمؤتمر، وان شاء الله كده هنبتدي بدري لان اليوم طويل. اي نعم الاتندنس لسه مش عدد الكامل يعني، لكن هنبتدي ان شاء الله. وهتكون معانا النهارده الاستاذه الدكتوره ساميه بسيوني، استاذه التخاطب في جامعه عين شمس، وهتكلمنا ان شاء الله عن neonatal dysphagia, feeding and swallowing disorders, assessment and management. اتفضلي دكتوره ساميه.
Thank you, Mr. Chairman. Thank you, Mrs. Chairman. Good morning, ladies and gentlemen. I would like to thank Professor Hisham Awad and Professor Safa Shafiq for inviting me to come over to share with you this wonderful event. As for my presentation, I will talk about the assessment and management of feeding and swallowing disorders from the phoniatric point of view. What is the role of phoniatrician in the assessment and management of feeding and swallowing disorders? We have several referrals from the neurology, ENT department and the pediatric department, whether from the NICU or outside the NICU, for infants who had feeding and swallowing disorders assessment. Let's start by differentiating between is a feeding disorder or is it a swallowing disorder. Feeding disorders are defined as problems with eating activities, such as no suckling or weak suckling during breastfeeding or bottle feeding. But there is safety in swallowing. There is inefficient swallow, but there is safety in the swallowing itself. However, in swallowing disorder, the suckling could be good, but there is a compromise of the swallowing within the 4 stages of the swallowing, whether oral preparatory or the esophageal or the pharyngeal phase of the swallowing. But there is the problem here is the dangers of aspiration pneumonia, so the safety of the swallow is compromised. As for the 4 phases of swallowing, it could be the oral preparatory phase, inadequate lip closure, disturbed tongue movements, loss of food from the mouth, and mastication problems. The oral transport phase here, we're talking about here, prolonged oral transport due to reduced tongue strength, pooling in the pharynx, and reduced induction of the swallowing reflex, poor initiation of the swallow reflex, or premature spillage. Pharyngeal phase, as we said, there is a nasal regurg of food from the nose, penetration and aspiration within the larynx, or residue after the swallow within the valvulae or the pyriform sinus. Here in the pyriform or in the valvulae, residue after the swallow, or reduced pharyngeal contractions, pharyngeal squeeze. Esophageal phase is also observed. We can have motility disorders or gastroesophageal reflux. I look for the causes of your referral for me as a phoniatrician to assess the feeding and swallowing problem. Sometimes you report no suckling or weak suckling, loss of saliva during the feeding, nasal regurg during feeding, alterations in breathing, tachypnea or apnea, bradycardia during feeding, frequent coughing during feeding and choking, circumoral cyanosis, excessive gagging, noisy breathing during the cry, may be indicating an airway problem, fatigability or lethargy during meals, prolonged feeding times, weight gain is a concern, and at the end, we are afraid of the delayed hospital discharge, and there is a concern for gastrostomy or nasogastric tube insertion or the tracheostomy. As for me, I have to look for the etiology. Why are you referring the case for me? Maybe cerebral palsy, traumatic brain injury, perinatal anoxia, muscle weakness such as neuromuscular disorders, muscular dystrophies, myopathies, neuropathies, prematurity with developmental impairments, immature neuromuscular control without prematurity. Maybe without prematurity, you can see immature neuromuscular control. Anatomical structure abnormalities, congenital, such as laryngomalacia, laryngeal clefts, bilateral vocal fold paralysis, subglottic stenosis, tongue tie, tracheoesophageal fistula, esophageal atresia, cleft palate, or post-alveolar cleft, whether pre-alveolar or post-alveolar or alveolar clefts or submucous cleft. All of these are congenital anomalies, would raise up to a feeding disorder or a swallowing disorder. Genetic syndromes such as Down syndrome with weak suckling, genetic syndromes such as golden hair. I've just seen 2 of these cases with nasogastric tube insertion and inability to manage their saliva with cardiac defects and cleft lip and palate. Secondary to systemic disease such as GERD, respiratory or cardiac disease. If we talk about the pathophysiology, what's the pathophysiology of feeding difficulties? If we talk specifically about prematurity, the neurological immaturity due to the underdeveloped CNS may lead to feeding problems, inability to suck or slow or weak suckling, inability to coordinate breathing, swallowing, and breathing, which we're talking about with Dr. Safa this morning. It's expected to be under 37th week. So it will lead to desaturation, bradycardia or apnea or aspiration during the feeding because of the feeding or the neuromuscular control is not developed yet. And then a difficult transition from tube feeding to full oral feeding with a delay in the hospital discharge. If we talk physiologically about the cricopharyngeal opening, the upper esophageal segment, the cricopharyngeus is located in the upper esophageal segment. It should relax 0.1 of a second before the thyroid and cricoid cartilage, the higher laryngeal excursion. In order for this to happen, it has to open the sphincter physically. So in immature infants, actually, this doesn't happen. This is what it looks like normally. Normal swallow, normal flow with no penetration or laryngeal aspiration, and it goes directly to the upper esophageal segment. But this doesn't happen normally in the immature infants because of delayed maturation. So the propulsive forces in the pharynx, when they reach their peak, the sphincter doesn't open because the immature neuromuscular control during immaturity. So this can lead to penetration and aspiration. The consequences of those feeding and swallowing problems, the unpleasant medical procedures in what happened in the NICU carried out in or around the infant's oral area, such as nasopharyngeal suctioning, intubation, nasal feeding, and tapes, have a negative effect on the oral motor control and sensation, and could lead later on to oral aversion and long-term feeding problems. And then poor weight gain, failure to thrive, dehydration, aspiration pneumonia, and the concern of a nasogastric tube insertion or gastrostomy, and the delay in the transition from tube feeding to full oral feeding with a delay in the hospital discharge. 40% of those cases which are seen in the dysphagia clinics are former preterm infants. We see them as a preterm, and then they are followed up in the dysphagia clinics. So they contribute to delays in the emergence of oral motor behavior, such as babbling and speech and language production, and delay in the oral feeding, and they develop oral aversion later on with long-term feeding difficulties, such as those that we can see in the toddlers as presenting with eating disorders of early childhood. It has a lot of synonyms according to the Diagnostic and Statistical Manual, DSM-5, benign picky eating, tactile defensiveness, sensory food aversion, toddler anorexia, functional dysphagia, neophobia, food avoidance, emotional disorder, and pervasive refusal syndrome. It has a lot of pillars: behavioral disturbance during a meal time, neophobia, refusal of any new food, strong food preferences, or soft, going on or soft or blended food. When it comes to the assessment and treatment, the urgency of effective assessment is to promote safe and efficient swallowing, not only efficient, but safe, in order to prevent aspiration pneumonia. Reaching oral feeding for a preterm infant and newborn is one of the prerequisites for NICU and hospital discharge. It's a multidisciplinary approach: the pediatrician, the neonatologist, phoniatrician, clinical dietitian, lactation consultant, neurologist, plastic surgeon, and pediatric surgeon. We begin with the bedside assessment, the history taken, we analyze all of the complaints for which you have referred the patient. History of pneumonia, history of weight loss, the elimination, nasogastric tube, oral gastrostomy, tracheostomy, prolonged feeding times, total volume consumed, amount of supplemented oxygen if required, supportive actions by the feeder, or management of saliva. Does he manage the saliva or not? Fatigability during feeding, increased respiratory rate or effort, inability to coordinate suck-swallow breathing, which is expected until 37th week, symptoms of aspiration, change in voice quality. There are a lot, if you review the literature, there are a lot of neonatal feeding assessment tools. The most common ones are the NOMAS and the Latch and the EFSA. The EFSA is the well-known. It has a lot of domains. It's just a yes or no question, and it's very necessary during the assessment of the bedside assessment. We begin with trial feeding, observing pre-feeding baseline, oral feeding readiness, ability to maintain engagement during feeding, and ability to organize oral motor function. Observing the sucking, observing the rhythmic and smooth organized sucking, sucks with intraoral sucking pressure, tongue maintains steady contact with sucking bursts, long sucking bursts, 7 to 10 sucks without any distress signs. As you can see here, the baby observed and developed circumoral cyanosis once he got feeding. And then saliva managed, does he manage the saliva or not? Or there is a drooling, tongue mobility, nasal regurg during feeding, coughing or choking, indicating something is entering the trachea or the airway, changing in the voice quality after the feed or during the feed, and respiratory signs, is there apnea, desaturation, tachypnea, and so on. Like this baby I want to show you, he's been in the NICU for 3 months and he was not able to be discharged because whenever he's fed through the bottle, he develops stress cues such as intercostal retractions, and fussy and crying and worried look. Although he has a good swallow and he has a good sucking, but nobody knows, maybe he has a silent aspiration. So that's why we have to resort to videofluoroscopy and video endoscopy to see what's going on during the feeding. Non-nutritive sucking evaluation, we have to evaluate the non-sucking evaluation, the pacifier. Is there a rooting action, easy beginning of sucking, labial sealing, tongue central groove, jaw raising, lowering movement, sucking rhythm, and strength. The disadvantage, as I said, of the bedside assessment, we cannot exclude there is a silent aspiration because 40% of those cases are missed, and maybe they have silent aspiration and nobody knows during the bedside assessment. That's why we resort to videofluoroscopy. Videofluoroscopy, as you can see, the baby is sit in the upright position, the same as the adult position exactly, and the neck and head and neck area is exposed to the X-ray. And here, you can give the baby the bottle feeding very comfortably, and you can observe what's going on during feeding in the oral preparatory phase and esophageal and even pharyngeal, and you go down with the beam to see the esophageal phase. As for the consistencies, the normal consistency that we give, thin liquid, thick liquid, semi-solid, and solid consistency. But in the babies, we resort to the thin liquid, just barium with water, or barium with, of course, in the infants, we give pumped breast milk or the formula mixed with barium 4:1 consistency in order to be simulating the thin liquid consistency, and you observe what's going on during the monitor room, and you observe during the checklist what's going on during the swallow itself, commenting upon the oral preparatory phase, oral rantry phase, pharyngeal phase, and the esophageal, and denoting specifically is there any laryngeal penetration, aspiration, and the residue, and where is the location of the residue, whether in the valleculae or the piriform fossae or all around the pharynx, may be indicating weak pharyngeal peristalsis. Aspiration, the timing of the aspiration is very important, whether it's before the swallow, indicating a delayed triggering of the swallow reflex or a premature spillage, or during, maybe indicating inefficient closure of the larynx, and the residue and the aspiration after may be indicating tracheoesophageal fistula after the swallow, and the transit times. As this baby, you can see and spot very, very minute, thin aspiration during the swallow. Because of inefficient hyolaryngeal excursion, the penetration and aspiration is going from up position, and it's not through a tracheoesophageal fistula. It's from the up because of the hyolaryngeal, deficient hyolaryngeal excursion. This is a 1 month-old baby presenting with bilateral vocal fold paralysis. However, there is no dysphagia. The swallowing is very efficient and there is no laryngeal penetration or aspiration, but his otolaryngologist referred him because of he was scared that he might have a dysphagia problem beside the airway problem, because he had a bilateral vocal fold paralysis and he has a noisy breathing. So just wanted to exclude that there is a dysphagia accompanying the airway problem. This was at 2 years old. I followed him up since he was a baby. He was having a spinal muscular atrophy, which affects all the muscles of the body with muscle weakness. Although, however, he had a very severe muscular here in coordination here and severe cricopharyngeal dysfunction, closing the upper esophageal segment and causing aspiration through this severe cricopharyngeal dysfunction. This muscle was not able to be relaxed at all. So he developed aspiration, and he was on a nasogastric tube for a long time, and he ended up with a gastrostomy. It's a life-saving procedure because of several pneumonias he developed. This was a case of a severe GERD. Unfortunately, he was mistreated by a fundoplication, which ended up with esophageal atresia. So it's just a take-home message. Don't ever think that the severe GERD will be treated by fundoplication, because it might end with gastric or esophageal atresia. Video endoscopy is another way of assessment of the feeding and the swallowing by induction of the endoscope during the nase. It's exactly like the adult, and watching premature spillage or the delayed trigger of the swallow reflex, any laryngeal penetration or laryngeal aspiration, and the timing. Here you watch the laryngeal inlet and see whether is there any residue in the valleculae or the pyriform sinus, whether entering in the larynx or not during the white out phase, during the swallow. This is the white out phase during the swallow, and then following up, this is the tracheal rings, and you can see the aspiration within the trachea. As for the management, is directed for the cause. If there is an organic cause like laryngeal clefts or laryngeal cleft and palate, it's managed accordingly. Surgical, bilateral vocal fold paralysis, subglottic stenosis, moderate or severe, subglottic hemangioma, tracheoesophageal fistula is managed accordingly by referring him back to his ENT and esophageal atresia. As for reducing, as we have said this morning with Dr. Safa, during the NICU, even the patient is with having an nasogastric tube, we start with reducing motor sensory based feeding difficulties like oral and perioral motor sensory stimulation, provide sensory motor input during the feeding itself. And outside the feeding, we can have external and internal cheeks, upper or lower lips, upper or lower gums, lateral borders of the tongue and mid-blade, and assisted jaw. Just by gentle touch and gentle pressure, it stimulates according to Thoyer et al. This is the stimulation program. Fossil et al. 2002. You start within the NICU, even the patient having an nasogastric tube, you start very early to reduce the motor sensory based feeding difficulties by applying pressure to all of those areas: external cheeks, internal cheeks, upper and lower lips, and the tongue blade and the internal cheeks. According to the program, the oral motor exercise we follow up later on by the tongue lateralization, tongue elevation, and so on, and jaw exercise later on. The advantages of the oral motor sensory intervention: it reduces the length of the time to transition to full oral feedings in preterm infants, and increased overall intake and higher breastfeeding rates. And of course, it would act on the hospital discharge. We all want the hospital discharge will be very speedy. And of course, for the non-nutritive suckling, we work on the pacifier. stimulating the lower lip, elicit a suck with the finger, and elicit a suck then later with the pacifier. The advantages of the non-nutritive suckling: a positive impact on infant state, reduces defensive behaviors, and improves overall feeding performance. Of course, latching difficulties, all of these latching difficulties and the volume of the milk and nipple chill, nursing supplementer, I refer back to his lactation consultant to deal with all of these problems. Like our guy, which was not be able to be discharged from the NICU, we began the oral motor exercise with the nasogastric tube. As we have seen, he had developed oral motor problems, and then we began the oral motor exercise during the NICU until he discharged from the NICU later on. Compensatory stretches such as proper position of the baby, adjustment of the feeding rhythm, pacing, adjustment of the bolus volumes by teats or spoons, and using thickeners. Natural, of course. There are a lot of utensils outside in the market, such as oral light and talk tools, as they are used in adults as in children, but we use the proper ones for the babies. We begin for icing for older patients of ours, icing and the gum massage for older ones who developed oral aversion and hypersensitivities, stimulating the gums, the palate, the tongue as like the baby, in order to reduce the hypersensitivities or the hyposensitivities, using the utensils such as the prefers with the proprioceptive ends. And then I just have 1 minute. Okay. Prefers, and there are an oral motor kit. It's Egyptian. You can find it here in the Egyptian market because all of them are very expensive, and start with a teether or all of these kits. And then there is the prefer with the tactile and vibration. Sometimes most of the children cannot tolerate the vibration, so they go on the normal prefer, the grabber and the textured grabber, and learning going on to bite and chewing, because those children who develop aversion cannot have the sense of biting and chewing later on. Because of the aversion they develop, they cannot even tolerate the touch of anything within their mouth because of the hypersensitivities they developed earlier in life. And then textured spoons, textured grabbers, textured spoons, as we said, in both surfaces. And then if there is a tongue protrusion, you can go on the straw very early in life. Tongue lateralization and tongue elevation is used later on for any tongue problem and tongue deviation or weak tongue mobility. And if there is a hyperactive reflex, and we can see this a lot with hypersensitive patients, we give the oral sensory stimulation by the 0-0 laryngeal size mirror for the tactile stimulation in the oral arches. Thank you very much.
شكرا دكتورة سامية على المحاضرة الجميلة دي. يعني أنا لسه كنت بكلم حضرتك من قبليها ولا فعلا احنا عندنا مشكلة إن البريتيرمز من كتر ما بيبقوا قاعدين في الحضانة ويطولوا مركبين راعي، ونيجي فجأة نفكر نرضعهم ما بيرضعوش. I think إن دي بروبلم كويسة، وحضرتك تاكل نقط معينة جدا، وأتمنى إن احنا كلنا نبقى واعيين بالموضوع ده من بدري، يعني أويرنج الموضوع ده. شكرا دكتورة سامية، ميرسي، اتفضلي.
بسم الله الرحمن الرحيم. طبعا أنا يعني مش عارف أقول، أنا ببقى سعيد جدا وأنا موجود في هذا المؤتمر المتميز بين التيم الرائع الحقيقة تيم نيوناتولوجي